Well, thank you very much for taking the time to come to tonight's symposium. And we have a number of good speakers tonight, and I hope you'll enjoy the presentations. I was asked to sort of give an introduction to the concepts of ischemic conditioning. And some of you in this room may be very familiar with the concepts, and others may not. So this will be a little bit of a primer on the concept. And for those of you who are familiar with this, it may cover some old ground, but may include some new things as well. So this slide is basically from work from Sharon Hale in our laboratory at the Heart Institute of Good Samaritan Hospital in USC. And this is a study in which anesthetized rabbits were subjected to 40 minutes of coronary occlusion and reperfusion. And then at the end of that reperfusion phase, we re-occlude the artery, inject a blue dye, which goes through the vasculature, and everything that's not blue in these left ventricular slices is what's called the ischemic risk zone. So the blue areas of the left ventricle here are non-ischemic, and everything that's not blue, did not get the dye, is in the ischemic risk zone. And then these slices are incubated in a substance called TTC, or triphenyltetrazolium chloride, that stains viable myocardial cells brick red, and the myocardial infarct appears as a white pale area. So you can see this rabbit ventricle on the left here has a very large myocardial infarct, as shown here. There's a little bit of viable tissue here, but this is a large confluent area of necrosis. This was a control animal. On the right is an animal that received ischemic preconditioning. So prior to the 40-minute coronary occlusion, this animal received 2 5-minute episodes of ischemia and reperfusion. So that 5 minutes of ischemia does not cause necrosis. That would be like an episode of angina, if you would. But this brief period of ischemia and reperfusion, this conditioning, this preconditioning, results in a much smaller area of necrosis. And these areas of necrosis, which are these white zones, are small, they're little islands or peninsulas, and there's a lot of viable myocardium here, shown by the red. So ischemic preconditioning reduces infarct size. This is not some abstract concept. You can see it, and it's very obvious. And the preconditioning phenomena really is the heart's own self-preserving mechanism. Brief periods of ischemia of 2 to 5 minutes prior to a longer duration of ischemia reduce infarcts. In most models, reduce ventricular arrhythmias. And of course, if we can learn the mechanism of preconditioning, it can lead to potentially important therapies. Now, Chuck Murray, Keith Reimer, and Robert Jennings were really the first to describe ischemic preconditioning. They did this in a canine model of 40 minutes of proximal circumflex occlusion and reperfusion. Control animals did not get conditioning. Conditioned animals, or ischemic preconditioning animals, got brief 5-minute coronary artery occlusions and 5 minutes of reperfusion times 4. If you look at infarct size as a percentage of the risk zone, control is shown here, preconditioned animals are shown here, a marked reduction of infarct size, and importantly, no change in regional myocardial blood flow measured by microspheres. So this conditioning mechanism is not recruiting collaterals to explain this phenomenon. There's clinical evidence for preconditioning. Some of these papers include less chest pain, less ST segment elevation, less lactate production with subsequent compared to first angioplasty balloon inflation, reduction of myocardial infarct size and mortality and heart failure in patients who've had a history of angina prior to an acute myocardial infarction, acute tolerance to angina, the so-called warm-up phenomena, and also studies performed on human cardiac tissue looking at ATP levels during CABG in patients who were conditioned or not conditioned, in vitro studies on isolated human muscle, and in vitro studies on human myocytes where ischemia and reperfusion is simulated in vitro. This is a study that we did in collaboration with the TIMI-4 investigators, including Drs. Cannon, Kay Brownwald, Dr. Schicklink was also involved in the study. These were patients who were part of the TIMI-4 study, which was a study that looked at various thrombolytic regimens for opening up occluded coronaries in patients with ST elevation MI. And we observed that patients who had had histories of angina prior to their infarct had lower infarct sizes assessed by CK units compared to those patients with no angina. And in patients who had pre-infarct angina, there was also significant reductions in in-hospital death rates, severe heart failure and shock, and the combination of death, severe heart failure, and shock. And there have been a number of studies that have confirmed that have seen that phenomena. Now, the problem with preconditioning in the setting of acute MI is that how are you going to do it? Because myocardial infarcts are unpredictable. We don't know when they're going to come on. And so there is a concept called post-conditioning, which may be more clinically relevant. Now, post-conditioning is the phenomena whereby several brief coronary artery reperfusion reocclusion cycles at the end of a long coronary occlusion, or stuttering reperfusion, as I like to call it, reduces myocardial infarct size. And initial studies by Zhao and Yang showed that this phenomena did occur. This was work from Vinton, Johansson, and Zhao's group at Emory, in which anesthetized dogs were subjected to LAD coronary occlusion for 1 hour, and they were either reperfused quickly just by opening up the artery, or they received stuttering reperfusion with 30 seconds of reperfusion, 30 seconds of reocclusion times 3 prior to reperfusion. So this is post-conditioning. You're inducing the conditioning stimulus after the coronary occlusion is released. And in this study, they compared the percent of the risk zone that developed necrosis in control animals and animals that underwent post-conditioning in the dark area, the dark bars here, and in preconditioned animals. You can see that in their study, post-conditioning was really as good as preconditioning. Now, not all labs have confirmed that. Some have. We've not found post-conditioning to be beneficial in infarct size in our laboratory, although others have. However, we have found post-conditioning to be a very powerful antiarrhythmic agent for reperfusion arrhythmias. So in a rat model, Dow and coworkers in our lab exposed rats to 5 minutes of occlusion, 10 minutes of reperfusion as a control, and then there were post-conditioned rats who received 4 20-second occlusions separated by 20 seconds of reperfusion, and then 10 minutes of reperfusion, and we recorded and calculated the number of arrhythmias during the long reperfusion phase. So here's a typical control rat, and in this rat you can see with reperfusion there's ventricular premature beats and then a run of ventricular tachycardia associated with a fall in blood pressure. In contrast, in animals that were post-conditioned, we typically saw a lack of arrhythmias during the longer reperfusion phase, as shown here. And this was an animal that was treated with post-conditioning and sinus rhythm. And here's the sum of the data. So any arrhythmias was significantly reduced in those animals that were post-conditioned compared to those that were non-post-conditioned. Ventricular tachycardia was reduced. Ventricular premature beats were reduced with post-conditioning. And we've shown this now a number of times in the rat model. Well, post-conditioning has also been studied in humans, and there is some reason to be optimistic about this. This is work from Stat and Michel Ovies. Michel actually was a former fellow of ours at the Heart Institute of Good Samaritan in USC in the 90s. When he went back to France, he did a study in which they took patients with acute ST segment elevation MI. They were randomized to control, which included direct stenting and acute reperfusion, or post-conditioning. Post-conditioned patients had stenting, but then the angioplasty balloon was reinflated for 1 minute, then deflated, then reinflated, and these periods of reperfusion and occlusion were repeated 4 times until full reperfusion occurred. And what Stat and coworkers described was that myocardial infarct size assessed by CK release was significantly lower in post-conditioned patients compared to controls. And so this was really the first clinical study showing in an MI situation that maybe post-conditioning would limit infarct size. And they also showed some other benefits. One was there was an improved blush grade in patients who were post-conditioned, and there was a more rapid reduction of ST segment elevation, both of which suggest that reflow was better. So there was perhaps no reflow in this model. There's been tons of studies to try to define the mechanism of conditioning, including post-conditioning. We don't have time to go through all of these now, but one of the mechanisms that comes up again and again is the concept that an end effector might be the mitochondrial permeability transition pore, which opens under conditions of ischemia and reperfusion. And when cyclosporin was given by Pio-Novis and coworkers, which is an agent that keeps that transition pore closed, they actually found that cyclosporin was associated with smaller infarcts in patients with ST elevation MI, and they published that in the New England Journal of Medicine. Other investigators have shown benefits of post-conditioning in the cath lab. This work by Lasky showed that post-conditioning performed during PCI for ST elevation MI improved ST resolution, coronary flow reserve, and measures of microcirculatory function, as well as reducing tissue necrosis. Now, I think one of the most exciting concepts is the concept of remote ischemic preconditioning or ischemic conditioning at a distance. And the founder of that was Dr. Karen Schicklink, who is here tonight, is going to go into more detail on that. And she really discovered that phenomena in our laboratory back in the early 90s and discovered that ischemic conditioning of one vascular bed may protect a remote vascular bed, and this could occur within the same organ or between different organs. And she showed that brief episodes of ischemia in one vascular bed of the heart protected the remote virgin myocardium from subsequent sustained coronary occlusion in the canine model. And in her study, she induced preconditioning using the circumflex artery with a test coronary occlusion of the LAD artery, and found that animals in this study that had preconditioning of the circ bed actually had a remote beneficial effect on reducing infarct size in the LAD bed as manifested by a lower area of necrosis over risk. And she'll go into more detail of this concept during her talk. But let me also mention that a few years later, Dr. Birnbaum in our lab described ischemic preconditioning at a distance by making the limbs ischemic. And he showed that reduction of myocardial infarct size occurred by partial reduction of blood supply combined with rapid stimulation of the gastrocnemius muscle in the rabbit, and showed that remote ischemia of a skeletal muscle could precondition the myocardium. Other investigators also showed these kinds of phenomena, including protection of other organs. A very interesting study was published by Dr. Bacher and coworkers. This was a clinical study of remote ischemic conditioning before hospital admission as a complement to angioplasty, and looked on the effect of myocardial salvage in patients with acute MI. He looked at 333 patients with the first acute MI randomized to either primary PCI with or without remote conditioning, which in that study consisted of 4 cycles of 5-minute brachial artery cuff inflation and 5 minutes of deflation. And this was begun actually before the patients got to the hospital in the ambulance. The median salvage index by myocardial perfusion imaging was 0.75 in remote conditioning group versus 0.55 in the control group, which was statistically significant, and he and his group concluded that remote ischemic conditioning before hospital admission increases myocardial salvage and is safe. And here's data where he's plotted area at risk versus final infarct size, showing that patients who received this remote conditioning in the ambulance had a smaller area of necrosis for any amount of risk zone. So, in summary, ischemic conditioning has many potentials in terms of treating a whole host of situations. One is it may reduce myocardial infarct size, and this has been shown now by numbers of investigators. Reducing cardiac damage during percutaneous coronary intervention, protecting the myocardium during coronary artery bypass grafting and other procedures requiring cardiopulmonary bypass, protecting the vasculature during vascular surgery procedures, perhaps unstable angina, before activities that reproducibly cause angina in patients with stable angina, protecting donor hearts before excision and transport, and maybe protecting other organs such as brain or kidney during episodes of ischemia. And as you're going to hear tonight, this concept has now been expanded, really. with evidence that conditioning may actually improve endothelial function, that conditioning may actually improve exercise performance. And so there's a whole host of areas where conditioning may now be applied to humans. So thank you very much for your attention.